I want to call this hearing to order. Good morning, all. Welcome Dr. Martinez-Lopez, General Crosland, General Dingle, General Miller, Admiral Gillingham. Thank you all for joining us today. I want to especially welcome Dr. Martinez-Lopez and General Crosland. This is the first time briefing this committee, and we look forward to hearing your brief. I also want to recognize Admiral Gillingham, who is retiring later this month. I think thank you for your service isn't quite adequate. We appreciate everything you've done over your career to keep this country the greatest country on earth, and so we appreciate you. We wish you much luck in your next phase of your life, and just know that Maine or Montana are great places to retire to. So,
yes, sir. Thank you.
Look, the Defense Health Program accounts for roughly $39 billion, or 5% of the DOD budget. The Defense Health Agency is charged with providing health care services to 9.6 million service members, their families, and retirees through TRICARE. Its mission also includes managing the DOD Medical Research Program. And I want to acknowledge that the Defense Health Agency has not been immune from challenging trends in the national healthcare industry. These include escalating costs and a shortfall of providers. I hear this firsthand from service members and veterans in Montana who tell me that TRICARE is not working for them in rural America. So today, I want to have a candid discussion about the Department's delivery of healthcare and medical readiness of our force. The defense budget has enjoyed robust top-line increases in recent years. However, for this year, we have members proposing reduced and outdated funding levels. Congress has repeatedly failed the department in recent years by putting you on automatic continuing resolutions and getting you a budget that is late. It is my hope that in this new Congress we can break through the vicious cycle of CRs, and I wholeheartedly support efforts to get back on track, and I know Senator Collins does too. So the committee needs to know exactly what reduced funding levels and a CR would mean for the Defense Health Program, including for our service members and their families, medical readiness, and medical research. We have much to discuss. The Defense Health Agency is in the midst of a significant restructure. We continue to hear about challenges with TRICARE, and I believe mental health is our biggest health care problem. There isn't a family in America that doesn't have a mental health care problem somewhere in their midst. So I want to thank you for joining this subcommittee this morning. I look forward to our discussion. Before you, go ahead, Senator Collins.
Thank you, Mr. Chairman. I appreciate your holding this hearing on the Pentagon's Defense Health Program. To each of our witnesses, thank you for being here and for your service to our country. I would echo the chairman's special thank you to Admiral for all of your years of service. Providing for the health care of our troops and their families is a no-fail mission. Unlike other health care providers, the military health care system must support and save the lives of our warfighters in battlefield environments. I look forward to hearing about the department's investments, both ongoing and planned, to train and posture medical units to be able to respond in contested environments far away from the safety of large hospitals or military bases. In addition, as the chairman has indicated, the military health system continues to undergo substantial changes intended to improve health care. All military hospitals and clinics are now managed by the Defense Health Agency rather than the individual military services. DOD's new electronic health record system appears to be on track to be fully implemented this year, yet problems remain with interoperability with the Veterans Administration. And the long-awaited awards for the next national TRICARE managed care contracts were recently announced as well. Will these transformations improve the quality and level of health care for our troops and their families. That is the bottom line. That depends on DHA having enough staff, hospitals, clinics, and private sector providers to provide ready access for the physical and mental health care needs of the 9.6 million service members, their family members, and retirees who rely upon the military health system. On this committee, we are also interested if the cost efficiencies promised by some of these changes have in fact been realized. The Defense Health Program also conducts innovative research that benefits our warfighters and the American public. For example, from 2007 to 2018, 11 FDA-approved drugs that benefited from congressionally directed medical research funded programs were prescribed to more than 139,000 times for cancer treatment, and that only includes those prescriptions within the military health system. DOD must continue to transform our healthcare system through this impactful research. It is unfortunate that here we are in March, and the President has yet to deliver his budget requests for fiscal year 2024. It is a little more than a month overdue. Nevertheless, I look forward to hearing from our witnesses about how the Department is using the resources provided by this committee for fiscal year 2023 and what resources will be needed to care for our service members, dependents, and retirees in the future. Again, my thank you to the witnesses and to the chairman for holding this hearing.
Thank you, Senator Collins. First briefer will be the Assistant Secretary of Defense for Health Affairs, Dr. Martinez-Lopez. You have the floor.
Chairman Tester, Ranking Member Collins. Chairman Tester, Ranking Member Collins, distinguished members of the subcommittee, I'm pleased to represent the Office of the Secretary of Defense to discuss the Defense Health Program and its contributions to the health and medical readiness of the Department. I am speaking today in advance of the formal release of the President's proposed fiscal year 2024 budget. I will outline the major activities unfolding in the military health system that will inform our soon-to-be-released budget proposal. The National Defense Authorization Act, NDAA, for FY 2017 enacted sweeping reforms to the organization and management of military medicine. The expanded responsibility of the Defense Health Agency are now largely completed. The DHA exercises authority, direction, and control over all the MTFs worldwide. Lieutenant General Crosland, the Director of the Defense Health Agency, will provide further details on specific initiatives that the DHA is undertaking. This same law directed DOD to restructure or realign MTFs to support the Department's readiness requirement. However, in FY23 NDAA placed a one-year moratorium on any changes to the configurations of our MTFs. As requested, we are preparing an update to Congress on our way ahead in the coming month. The NDAA also included a 5-year moratorium on further military medical personnel reductions. Together with the Joint Staff, we are updating our medical requirements, as COCOM operational plans are also updated. We are conducting a comprehensive internal review with our OST colleagues and the military departments on the best configuration of medical infrastructure and personnel for the long term. We are resolute in our commitment to ensure combatant commanders have the medical resources necessary to protect, treat, and provide long-term care medical services to our men and women in uniform. We are also committing resources and attention to the ongoing challenge of suicide, both among uniformed service members and family members. We recently received the recommendation from the Suicide Prevention and Response Independent Review Committee and are continuing to implement strategies that can help reverse the heartbreaking trends that we have witnessed, both in DOD and in the nation. The department remains grateful for the long-term support from this committee for our military medical research in those areas of most pressing needs and relevance for today's emerging threats. That includes infectious diseases, combat casualties, and other areas of importance to our warfighters and to Congress. For the current fiscal year, our mid-year review is underway. As in past years, the MHS continues its sustained decade-long track record in responsibly managing healthcare costs, which remain below the national health expenditure per capita rate. Our FY 2024 budget will present a balanced, comprehensive strategy that aligns the Secretary's priorities. We look forward to working with you over these coming months to further refine and articulate our requirements. Thank you for inviting me here today to speak with you about the vital role of military medicine in supporting our national security. I look forward to your questions.
Thank you, Doctor. Next up, we have Director of the Defense Health Agency, General Crosland.
Chairman Tester, Ranking Member Collins, distinguished members of the subcommittee, thank you for inviting me to join Dr. Martinez-Lopez and the services Surgeon Generals to discuss the Defense Health Program. I will add to Dr. Martinez-Lopez's remarks by briefly focusing on some of the critical capabilities of the Defense Health Agency in supporting the military departments and the combatant commands. As Dr. Martinez-Lopez also noted, my comments assess the current state and do not speak to the FY 2024 budget, which is not yet released. In 2022 and into 2023, the Defense Health Agency has been able to focus its resources to supporting operational requirements of the department while continuing to manage COVID-19 pandemic. There were a number of important milestones achieved by the Defense Health Agency in the past year that will continue to influence operations in 2023 and into 2024. For my opening comments, I will focus on just two. First, more than 50% of our military medical treatment facilities have migrated to our new electronic health record known as MHS Genesis. In a few weeks, we will deploy the system here in the National Capital Region, and that will take us to approximately 75%. We remain on track to have this system fully operational worldwide by 2024. This modern electronic health record platform will provide the department a powerful tool to support our readiness mission, improve interoperability and record sharing with care delivered in the private sector, and allow our patients to engage more directly with their providers in managing their care. The COVID-19 pandemic accelerated the department's use of virtual health. For the coming year, I will build on what we've learned and how our providers and patients effectively use this technology throughout this public health emergency. I'm creating a new digital health strategy that will expand our use of technology in ways that improve our training, our preparedness, access, and quality of care. I intend to work with the military medical leaders and industry partners to focus on what we can achieve now and build on our successes over time. In late 2022, after a multi-year process, the Defense Health Agency awarded the next generation of TRICARE contracts at a value of over $135 billion over the next 8 years. These contracts will deliver high-value, patient-centric care that integrates the military and the private sector care. In January, protests were filed that will slightly delay this transition. We're closely working with GAO and will ensure that the process is carried out in a fair and timely manner. Dr. Martinez-Lopez noted our current budgetary status and future plans. We appreciate that Congress continues to grant the department carryover authority, allowing DOD to maintain a better flow of funds to minimize disruption to healthcare services and our beneficiaries. I'm grateful for the opportunity to represent the men and women of the Defense Health Agency, and I thank you for inviting me here today. I look forward to your questions.
Thank you, General. Next up, we have Surgeon General of the Army, General Scott Dingell.
Chairman Tester, Vice Chairman Collins, and distinguished members of the subcommittee, thank you for the opportunity to speak to you on behalf of the 111,000 that comprise the total Army medicine force. I am privileged to serve as the 45th Army Surgeon General and Commanding General of the United States Army Medical Command. The U.S. Army is the most lethal and capable ground combat force in history. As the Army continues to modernize for multi-domain operations, it is imperative that our medical force remains ready, responsive, and relevant to conserve the fighting strength. The Chief of Staff of the Army, General McConville, says that winning matters. I agree, there is no second place in war. From Foxhole to the Fix facility, Army medicine has achieved a high survivability rate for soldiers wounded on and off the battlefield in recent decades. We did this by remaining agile and adaptive. We applied the lessons from operations and developed a holistic system for future operations in austere locations. My vision for going forward remains consistent with the Army Medical Modernization Strategy and nested with the Army Modernization Strategy, ensuring our medical force is trained and ready as an enabler of combat power. We will synchronize and integrate the medical effort within the Army, the Defense Health Agency, Joint Staff, and combatant commands to be responsive and steadfast to teammates of the Joint Force. This will ensure that Army medicine is responsive and relevant to execute the National Defense Strategy. We will also build readiness through our investments in people. Army medicine must be innovative and agile to remain competitive with the healthcare industry on our recruiting and retention practices while partnering with the DHA to deliver high quality and safe care. Army medicine remains engaged at echelon to confront the challenges associated with military service and suicide. Each life lost devastates the force, and Congress has spoken loudly. As the medical integrator, we actively support the modernization of the medical effort. Timely funding this year will expand our expeditionary medical capabilities and ensure that interoperability within the joint force. Medical reform will allow us to update our capability, design, and structure to optimize resources for operating and generating forces. Finally, we are strengthening our alliances and partnerships in order to enhance interoperability with the international community by providing institutional medical training, collaboration on medical research, development, innovation, and force structure design. Across the globe, we offer solutions to grow capability and capacity. In closing, I thank the subcommittee for your longstanding support to the Army and Army medicine. Our trained and ready medical force depends on timely, adequate, predictable, and sustained funding. Army medicine is Army strong. I look forward to your questions.
Thank you, General. Next up, we have Surgeon General of the Air Force, General Miller.
Chairman Tester, Vice Chair Collins, and distinguished members of the subcommittee, it is my honor to brief you today on behalf of 31,000 medical airmen. We respond to our nation's global needs during peacetime, humanitarian crisis, and hostilities. Our cornerstones are aerospace medicine and air medical evacuations, capabilities that have saved thousands of lives and ensure our warfighters come home with the best medical outcomes. Thank you for your past and ongoing support to modernize key readiness capabilities and sustain our force. Last year, I charged my leaders to evaluate and re-envision our readiness force and response structure. The objective is to provide combatant commanders with a well-trained and equipped medical force capable of adapting to rapidly evolving joint force requirements. I expect a modular growth capability with a smaller footprint than our expeditionary medical support system. It will increase operational abilities in contested and degraded environments, plus impact future capability requirements, training, sustainment, recruitment needs, and changes to the AFMS end strength mix. It will also improve our alignment to the Air Force's ACE construct. The initial concept was tested in wargaming tabletop exercises in January. Now we are refining and moving forward with a test at a joint exercise this summer. We must also focus on the daily readiness care of our airmen and guardians to address the challenges of their work environment. Occupational and environmental exposure risk assessments are critical. A current early-stage study on specific risks to the missileer community is ongoing. We will be transparent during this process, as our responsibility is to protect the health and safety of our airmen and guardians. We take that seriously. We are moving forward with our operational support teams to optimize performance and readiness using evidence-based strategies. Access to mental health care improved through our targeted care program. Members are vectored to the appropriate place for support based on individual needs, whether that is a mental health care provider or non-clinical support like group therapy. Family readiness also impacts member readiness. Those who are part of our Exceptional Family Member Program may now have access to expanded care and support through the Air Force Developmental Behavioral Family Readiness Centers. The program is rolling out as it uses a hub-and-spoke approach to support our members' families. Air Force medics are uniquely ready and capable to safeguard our interests both at home and abroad. Thank you again for your support to the AFMS and our medics. I look forward to your questions.
Thank you, General. Next, we have the Surgeon General of the Navy, Admiral Gillingham.
Chairman Tester, Vice Chair Collins, distinguished members of the committee, I'm pleased to be with you today to provide an update on Navy medicine. On behalf of our mission-ready One Navy Medicine team, please know that we are grateful for the support you provide us, as well as the trust and confidence that you place in us. Navy medicine is best described as well-trained people working as expeditionary medical experts on optimized platforms, demonstrating high reliability performance as highly cohesive teams to project medical power in support of naval superiority. These priorities guide our deliberate planning efforts, resource allocation decisions, and strategic program investments. We're at a critical and exciting juncture as we pivot from operating military medical treatment facilities, which are now completely under the authority, direction, and control of the Defense Health Agency, while our attention is on the operational mission of delivering manned, trained, equipped, and sustained medical units who provide enduring support to the fleet, the Marine Corps, and the Joint Force. This operational focus maintains Navy medicine's requirement to provide health services at sea and ashore on our platforms and in DHA MTFs. As you know, the national security and defense strategies make it clear that China represents the pacing challenge against which we must plan our warfighting strategies and investments. For the first time in at least a generation, we have a strategic competitor who possesses naval capabilities that rival our own and seeks to aggressively employ its forces to challenge U.S. principles, partnerships, and prosperity. Similarly, Russia, Iran, and other authoritating states continue to challenge the rules-based international order. Navy medicine is taking urgent action to support the Navy and Marine Corps and save lives in contested battle space that is quickly growing in lethality, complexity, and scope. Last month, I released our 2023 campaign order, which outlines our strategic direction for the next 5 years and directs foundational changes to our entire enterprise operates in order to meet combatant commander and component commander requirements for the warfighter. To get us there, we are working on several strategic imperatives, including new platforms in development, like the Expeditionary Medical Ship, which will speed to assist casualties and have 3 operating rooms and 60 medical beds. Thank you for the program increase in the FY23 Appropriations Bill to procure 2 additional ships. I was recently in Mobile, Alabama, representing the Secretary of the Navy as we christened the USNS Cody, which is our first Expeditionary Fast Transport Flight 2, with enhanced medical capabilities to augment the EMS. These platforms truly represent a quantum leap forward for Navy medicine's ability to meet our mission in future complex conflict on the water. And another key priority in ensuring our sailors and Marines have access to the full continuum of mental health resources, while aiming to utilize the right care at the right level at the right time. Embedded mental health remains vital for mental wellness by placing mental health as far forward as possible. Currently, 36.5% of active duty mental health providers and 31% of behavioral health technicians serve in operational and training commands. Navy medicine supports readiness from accession to separation, prioritizing resiliency efforts, suicide prevention, providing mental health services within primary care and specialty clinics, embedded within the fleet and via virtual health platforms, and deploying disaster mental health intervention. Navy medicine is most grateful to the committee for the resources to support our research initiatives, particularly in the areas of dental technologies and human performance. The ads that you provided will improve overall warfighter readiness and the medical treatments we provide. In summary, Our center of gravity is the commitment to provide expeditionary maritime medical care. Our ability to quickly deploy and support a crisis response around the world makes military medicine unique, but more importantly, demands that we're both operationally relevant and clinically prepared. Again, thank you for your leadership, and I look forward to today's discussion.
Thank you, Admiral. There will be 5-minute rounds, and I will yield to Senator Durbin.
Thank you, Senator Tester. Let me say at the outset, congratulations to you for leading this important subcommittee, which I've been honored to serve on. Let me respond to my friend Senator Collins. It is true that the administration is probably a few weeks late in producing a budget resolution, but our hope for the budget process this fiscal year lies in the capable hands of 5 people who were featured in a color photograph on the front page of the New York Times several weeks ago. It was an article that noted that we have reached an historic milestone. Both the director of the OMB, the chair and ranking members of the House and Senate Appropriations Committee are all women. You're here. I thought you'd like to hear that. I'm hopeful. I believe that you're going to set out, as Senator Murray has told me, and I know that you're working closely together to make history in that appointment, and I'm confident you will. So I wish you the very best, and I want to help you reach that goal. Senator Tester, I also want to say a word or two in praise. I'm sure you would give me additional time if necessary, in praise of your role as chairman. I set out 8 years ago to achieve 5% real growth in medical research by the Department of Defense and the National Institutes of Health. You were my partner in that effort, as was Senator Blunt of Missouri with the NIH. And I note that in the fiscal year 23 omnibus, you have appropriated $3.107 billion for medical research, 5% real growth. Congratulations, Chairman. I hope we can maintain that going forward. Let me address the issue that Rear Admiral Gillingham raised at the end, which I think relates to a number of our witnesses. My general question, I'll start with Dr. Martinez-Lopez. Mental health counseling is so important for all of us, and especially important in the military, where they're under stress situations and face trauma incidents on a regular basis. In the past, let's be honest about it, in virtually every aspect of medicine, there was a stigma attached to mental health counseling. And there was a belief that if you conceded that you needed counseling, it was a black mark on your record which would hold you back come time for promotion and advancement. Has that changed? Are you changing it?
Sir, I think, there's movement in the bullpen to really change that. Culture takes a while, but the department has been very entrenched, and I can speak for Secretary on down, that mental health is health. It's like anything else we need. So we need to really lower that stigma. People make it very available, close. So everybody will be very easy to get, just like get into sick call for an ingrown toenail or something like that. But I will tell you that still is an ongoing challenge that we're really making headways, but we're not done yet.
I can concede that point very easily in our own family circumstance. A member of our family served in Vietnam and came back from that military service a changed person. We never could quite understand what happened to him. He did some things which were not good for his family, for himself. It took him many years to come to grips with his experience in Vietnam. We used to euphemistically refer to them as the Vietnam generation. And I won't go into detail, but you know what I'm speaking of. Contrast that with those who served in Iraq. I noticed many times these young military veterans would come home and be very open and honest about the need for help and counseling. What a dramatic reversal that was over the Vietnam generation. I hope that is the spirit that the military is looking at this issue moving forward.
Senator, absolutely. I mean, we're committed for the overall well-being of all service members. And mental health is one of those issues that, thanks to God, now we can talk and put it on top of the table and address it the way it should be addressed. And in the Vietnam days, we didn't, for whatever the reason, we didn't talk openly about these kind of issues that needed to be spoken about. So Stigma is one of the issues of mental health, but there's obviously, it's very complex, and we're taking the public health approach to deal with the mental health crisis. And what that really means is it's not just a medical issue. It's an issue that encompasses personnel actions. It's an issue that encompasses financial issues. So anything that brings more stress, we need to figure out how to lessen that load on the service members. So it's not, everybody has to own on this exercise.
Thank you,
on
Doctor.
this issue.
Thank you very much. Thank you, Mr. Chairman.
Senator Collins.
Thank you, Mr. Chairman. Dr. Martinez-Lopez, let me follow up on the mental health issues that are of such concern to this subcommittee. You mentioned the Department's Suicide Prevention and Response Independent Review Committee, which recently released a report with numerous recommendations aimed at reducing the number of suicides. I want to make a couple of observations about that report before asking you a question. First, it is evident that the department needs to reduce the time that is required to recruit behavioral health specialists. In one example cited in the report, it took on average a year and a half to hire civilian psychiatrists and almost a year to hire psychologists at Walter Reed. So it's not a big surprise that half of the psychiatrists ultimately declined the position after that long delay. Undoubtedly, they went elsewhere. And that is unacceptable that we're losing people because it takes so long to bring them on board. Second, TRICARE's policy guidance is that 98% of the claims submitted by providers should be completed within 30 days. Yet the report found that behavioral health providers were reluctant to serve military beneficiaries because it took so long for TRICARE to pay them. One provider cited in the report said, "It takes forever to get paid a pittance, if you get paid at all." So obviously our military force will be stronger and healthier when more providers are available and more of them are willing and eager to accept TRICARE coverage. So here's my question. Will the upcoming budget requests include funding to implement the committee's recommendations?
Senator Collins, first, the Secretary and myself, I'm very grateful to the members of the committee for spending their time to come out with the recommendations, study it out, and helping us out with this big issue. Second, is the Secretary right now has a team, and we are leaning forward each of the recommendations, and we're looking at ways to, first, which one we're going to be able to accommodate first and which ones are going to come. And in that process, there will be issues of budgetary requirements. I'm not prepared to tell you what those are look like right now, but I'm telling you, we as a department, we're looking at all the one by one and addressing A, are they viable? Two, what will it take to implement those measures? So as we are ready to do that, we'll come back to you with the specifics, ma'am.
Thank you. General Crosland, just yesterday I met with a group of veterans from Maine who told me that the rollout of the new electronic health record system within the VA is still very problematic. Obviously, even if DOD is going to have its new system and 75% of its hospitals, as you testified, by the end of the year, if the VA is not in sync, we're still going to have a problem with transferring medical records once someone retires from the active duty military. And the veterans were telling me example after example of where they had difficulties in chasing down records, getting them to the VA. So how is DOD collaborating with the VA on the electronic health records rollout? and ensuring that once it's fully implemented, that there is the interoperability that we've been talking about for years,
Senator Collins, thanks for the opportunity to comment. First, ironically, last week I spoke with a senior leader within the VA and offered up the opportunity for them to come and witness our rollouts and to learn from our lessons on how we're able to execute our rollout and potentially things we can offer for them by sharing the lessons learned. With respect to that value of the record, there's a lot of value with the data, as I mentioned in my opening comments, having the right information, being able to follow service members from the time they're assessed all the way to the time they transition. And obviously, if there's a further delay in the VA's rollout, we would have to work through how we would hand our MHS Genesis electronic record that we're going to be on by the end of the year to the VA. We haven't gotten that far yet.
Thank you. I'm sure the chairman's going to solve that problem in his dual role.
No problem whatsoever. Moran's going to help me do it too. Senator, right? Yes. Okay, good. Look, it's a very good question, and I will just say that I don't know that there is anybody that is not frustrated with the whole electronic health record, the billions of dollars that are being spent, and it doesn't appear that we're moving the ball. So we've got some work to do. I want to start my questioning on TRICARE. I just had a town hall meeting in Montana. Things were brought up that I thought were solved, like providers that couldn't get in the network that offered up but couldn't get. Montana, I think you say this about everywhere in the country. Providers are something we need more of, not fewer of. And then the payments to those providers were not being done on time. So the providers that did sign up weren't getting their checks when they should have. So the question is who has oversight of it will be Tri-West? Who has oversight to make sure, number one, that they're bringing on the providers they need, and this is for you, General Crosland, they bring on the providers they need, and that the providers are getting paid, and, by the way, that the money that's actually going out to provide services and not being pocketed by somebody in one of these third-party providers' pockets.
So, Senator, the oversight of the TRICARE program is executed out of Defense Health Agency, so that would be my responsibility to engage with Tri-West to make sure they're honoring the aspects of the contract. We do have a pretty aggressive auditing for the last part of the concern that it's actually not going to the provider, but there's potential fraud. We do have a very robust program that looks at and audits that. With timeliness, working harder with TRICARE West is what I owe you and the team in Montana to make sure that they're meeting their contractual obligations. With respect to signing up providers, the managed care contractor are given targets. They meet those targets. I acknowledge that when they meet those targets for the beneficiaries, that doesn't always translate that appointments available. So specifically, if you sign up, it doesn't translate that we have actually put appointments out. So in the T5 contract, we've added that as a criteria, not just to sign up providers, but to make sure that there are appointments available for the patients to book with the providers.
So this was a small sample size, but I had providers there that had contracts with TRICARE, and I had ones that would like to get contracts with TRICARE that couldn't. These were mental health providers. So I don't know what the contract says about the numbers of people you need. I don't know if it's based on population or geography or what it's based on. But I was shocked by what I heard. I was just absolutely shocked. At a time when mental health has been already brought up here several times, when mental health is such a huge issue in this country and we're not bringing on as many folks as we can, doesn't make a lot of sense to me. I want to move on. I want to talk about China. It may strike you as an odd discussion in DOD healthcare, but we have troops in Japan and other places where number one readiness concern we hear about is lack of health care for the dependents and their families. and DOD civilians. Apparently, the Defense Health Agency recently barred DOD civilians from receiving care at military hospitals, forcing them to use local hospitals. Wow. I think this it's a disaster, and by the way, I think it's gonna, if it hasn't already, end up being an incredible recruitment challenge. We've also heard concerns about a lack of mental health care for dependents in Japan. This stops service members from deploying there, puts tremendous stress on military parents. These reports are concerning and were repeatedly delivered with a sense of urgency from senior military leaders on the ground. It's already been pointed out, China is our #1 pacing threat, so this impact on military readiness is alarming. I understand that DOD is now going to make some changes to this policy, but quite frankly, it should have never happened to begin with. General Crosland, was the impact on military readiness taken into consideration when announcing this change?
So, Senator, the change I believe you're referencing was a policy put out on the 22nd of December, and the policy limited the space available access to the system so that we could preserve readiness for the force, specifically saying that Space A would have to call in after 10 o'clock and they would only receive acute care. I've since issued guidance, and a policy was released last week that added clarity to that policy, which expanded care to the Space A. So the policy never targeted or short access for dependents and their family members. It was meant to make sure that they got the priority that they were supposed to get at the expense potentially of Space A. So we've removed the barrier for chronic conditions to open up at the community level access within our MTFs for our beneficiaries to include the DOD civilians. We signed that out last Thursday or Friday.
Okay, and so do you believe this fully addresses the concerns of the commanders in the field?
No, I do not believe this fully addresses the command of the field. I think the concerns are broader than the care that the Defense Health Agency is resourced to provide. So specifically in Japan, if you have a hospital, then all beneficiaries, active duty family members, in partnership with TRICARE ISOS, receives care from the host nation. I believe that that is also part of the concerns that are being raised.
Okay. Senator Moran.
Mr. Chairman, thank you. These discussions don't seem to leave us, whether we're in veterans or in defense appropriations. And the same challenges that have been described, particularly with electronic health records, are ones that we're facing in that arena as well. I want to focus my few minutes on a challenge that I have had in getting information from you going back to October. There was a period of time, and it continues, in which just military retiree after military retiree sought me, my staff, to tell me about a significant change in their pharmacy benefit. And they were now traveling much further, or would have to travel much further than previously. Then that was followed up by the pharmacists who have struggled to keep their contracts with your agency, or the story of a number of major pharmacy chains who have declined to continue dealing with the Defense Health Agency. So in Kansas, a pretty darn rural state, perhaps you will tell me that the requirements are being met for the amount of travel time or distance that you must meet. But the inconvenience to veterans is significant, and the complaints are real and continuing. In October, I tried to get information from you. I was told this morning that the letter is in the mail. Not quite those words, but in the phrase that we often use. But I and a handful of my colleagues who were experiencing the same thing have sought the analysis that was done a long time ago that would explain the decisions that you made. And 6 months later, we still don't have that information. I've submitted requests for information through letters and through RFIs to the department. I went and visited with General Milley, seeking his help to get answers from the Defense Agency, Health Agency. but I am disappointed by the lack of cooperation that has been extended to me and to my constituents in an oversight responsibility that I have. I have heard the department blaming pharmacists for leaving the TRICARE network, but I also think that narrative is unfair and not accurate. There were winners and losers in the initial solicitation of contracts. Some pharmacists were continued in-network and never received an amendment, while others received rates lower than the cost to fill the prescription, effectively removing them from the network. A question, perhaps to you, General Crosland, how did the contractor decide which pharmacies received an amended contract at a much lower reimbursement rate and which ones did not?
Senator, first, acknowledge the delay in getting back to you. And the letter is in the mail, and my apologies for that. I'm not read on to what the contractor's process for negotiating rates are. What I am aware of is what the decision process was in how many to include into the network. I understand that some of the independent pharmacies specifically in the initial bid felt like they did not have an opportunity to compete for the TRICARE. We released another opportunity on 1 January, I believe, and received a response from another round of independent and grew those numbers of independent pharmacies. Specifically for Kansas, 55% of the pharmacies are chain pharmacies, and 45% of the pharmacies
that are contracted with
ESI are independent pharmacies. Acknowledge that in rural areas, the burden or the field, when we say 98% of individuals are 15 minutes from a network contract. That will be in the letter that we send you, 98%. And so the change for drive time for Kansas beneficiaries is 95% of them are within 15 minutes of a pharmacy, and that leaves about 3,000 of your constituents that have to travel a little bit beyond 15 minutes. 99% is the overall number once we go outside of 15 minutes, within 30 minutes.
I would push back or just make the case that pharmacy is not just a commodity, it's a relationship, and our servicemen and women have had that relationship with their pharmacist for a long time, and to be told that it's no longer an option, and the pharmacist indicating they had no option to continue, is still problematic to me. The transition apparently was driven by a 2019 independent analysis that the department seems to be unwilling to provide to me. Is there a reason you cannot share that analysis so that I and others can analyze the methodology by which you reach these conclusions?
I actually don't have that answer,
Okay.
but I will get back to you for sure.
All right. And Dr. Martinez, my time has run, but I held your nomination. I put a hold on your nomination because of lack of cooperation from the Defense Health Agency. I lifted that hold. It served its purpose. I lifted that, well, it presumably fulfilled its purpose. I lifted that hold and voted for your confirmation. The commitment was that I would have the answers that I've been seeking since October and often since then by March the 1st. March the 1st has come and gone. I would ask for your help in fulfilling that commitment to me.
Sir, I thank you, and I thank all the members for supporting my confirmation process. And yeah, hold me up to that. As Ms. Mullins said, that response will be fairly soon.
I may be satisfied, but let's see what the response
Yes, sir.
is. Thank you.
I just want to touch on this. I'm very proud of this committee because there's some really good people in this committee. One of our jobs is oversight. I don't need to tell you guys over half the money we appropriate goes to the military. If somebody on this committee wants an answer, unless there's a classified reason for not having that answer, we should get that answer, and we should get it in short order. And so I don't think there should be any reason for a senator, and this goes for you guys and anybody that's listening, on this committee, when we're appropriating the money, not to get the answers we need. It's unacceptable. Senator Baldwin.
Thank you, Mr. Chair. Dr. Martinez-Lopez, as the department is well aware, the National Guard has become an integral part of our total force, one on which we've relied very heavily for the past 20 years for the global war on terror, and a long list of other missions. Increasingly, we have seen the National Guard activated on short notice to support national priorities such as pandemic response, domestic unrest, and securing our southern border. For the increasing reliance on short notice deployments makes readiness a very key concern for both the National Guard and for this committee. According to the National Guard, over 66,000 Guard members do not have health insurance. Would you agree that providing health coverage to all National Guard members would be an important part of improving readiness?
Senator Collins said the health of the Guardmen or reservists or active duty is of most important to all of us in the department. And the good news is because of you, they haven't, the first option is the TRICARE Reserve Select. So many of the members of the Guard and the Reserve will have the option to enroll in that program. If we want to expand that program, obviously we're going to have to look more in detail, so what does it imply?
That brings me to my second question. Would you agree that if a Guard member cannot afford TRICARE Reserve Select and they lack access to other forms of health care, that we should find a way to get them covered?
We really need, we need to figure out a way to care for, we need to figure out a way to make the health care that they need available. So,
okay.
Yes, I agree. I don't know how. Obviously, we're going to have to do the studies, but.
We have a bill for you. But additionally, can you speak to any impact to or cost savings for the Reserve Health Readiness Program if we were to achieve 100% health care coverage for members of both the National Guard and Reserve components?
Ma'am, I'm not prepared to talk about that, so I really would like to do a study and look at the background so I can make a formal statement.
Dr. Martinez-Lopez, in recent years, I've sought and achieved increased funding for organizations within the National Guard to hire additional mental health providers and to expand efforts to educate civilian providers on intervention strategies. We have also worked to include suicide prevention as a topic eligible for funding through the congressionally directed medical research program. But despite these efforts, suicide rates have remained stagnant among the Reserve and Guard populations since 2011. Last month, the department released its recommendations from the Suicide Prevention and Response Independent Review Committee. I particularly appreciate the report's holistic view of mental health and the inclusion of factors that, while not directly related to clinical care, nevertheless impact prevention efforts. For example, the report recommends properly funding morale, welfare, and recreation programs, particularly on smaller and remote installations, as well as recommending spousal employment programs. What is your assessment of how we can better apply resources to make progress in reducing this suicide tragedy?
Ma'am, as I said before, the public health approach is the way to go. I personally believe that. As a physician, we need to look at three things. We need to look at the risk factors that are affecting these service members and figure out a way to relieve them from those risk factors, right? If we're not paying them on time, that may increase the risk factor. So we should be able to figure out how to give them payment on time. If there's a family issues, we need to figure out how to deal with those family issues. So we need to look at those risk factors, and we need to look at, from the preventive standpoint, look at ways to decrease them. That's issue one. Issue two, on the treatment side, we need to figure out new ways to deliver the care. First thing we need to figure out is right care with the right provider at the right time. So we have to make that right on target because we don't have that many.
And would you agree that zero-cost health care to all members of our armed forces, regardless of duty status, is an important component of accessing that prevention care and treatment?
Ma'am, I will have to think and see what the repercussions of that before I make a statement, one way or the other. Okay.
Yield back.
Senator Murkowski.
Thank you, Mr. Chairman, and thank you to all those that are part of the panel here this morning. I know that there has been discussion about the Suicide Prevention and Response Independent Review Committee report on the impact of suicide within the military. This is something that we have been very keenly focused on in Alaska. Our focus really has been on Fort Wainwright, along with Eielson Air Force Base. Both of these were identified for site visits in Secretary Austin's independent committee to review the suicide prevention reports. I'm sure that you are well aware of that. I guess this would be a question for you, Dr. Martinez-Lopez, and I'm curious to know what level you all will be working, will be involved in Secretary Austin's implementation working group. And as you answer that, I would ask for, I'd ask for your commitment to visit some of our bases in Alaska as you look at that proposed suicide prevention report. And I would suggest that starting at Fort Wainwright would be a pretty good place to begin. And then, don't know if you are a walker, but encourage you to take the 3-mile walk from the furthest barrack. It was built back in the 50s, to the outdated and too small dining facility there at Wainwright. The sun's coming on and it's getting warmer, but I would challenge you to do it in the dark and at 30 below, as many of our soldiers have to do. So if you can speak to that.
Ma'am, thank you for the invitation, but I already accepted the distinguished senator from Alaska when I was doing my hearings. I have 2 places I need to go
Okay.
for the same topic, Alaska and North Dakota.
All right.
I'm working it now in April, so I hope to be able to. I've been there.
Yeah,
I did the Arctic Survival School a couple of years back.
good.
When I was doing aerospace medicine. But, so for a Puerto Rican to be out there in Alaska during those times. That was
You know,
quite a
we
challenge.
have significant Puerto Rican population out at Fort Greely, and they love it there.
Yes,
So,
ma'am. And I survived, obviously.
Yes.
Yes, this issue of, I already told you, I mean, this issue of suicide and mental health is very important to me. I'll be working with the team, and I'll be working with the secretary to address what we can do, short-term, mid-term, long-term. This is not a done and we're done. It's going to take us a while. It's a journey. Every day we're going to learn. Every day we're going to deploy new ideas.
So
But
can I ask on that, if I can just interrupt there, because we're going to be seeing the president's budget laid down here in the next day or so. And I don't know if you can speak to whether or not we're going to see any of this outlined or projected in the president's budget. You know, are we going to see certain military construction projects prioritized, certain programs prioritized that can perhaps help make a difference? Because we know we've got to do something, and just doing the studies doesn't necessarily save lives.
On my 8th day on the job, I really don't know the answer to that
Okay.
one. My assumption is yes, but can anyone else help me? We owe you an answer on that one.
Okay.
Senator, one thing I will add within the Army, we definitely have done that. And under General McConville's leadership, we have what's called quality of life, in which the commanding general, General Eifler, has been able, through a holistic approach, been giving resources and facilities that we're looking at adding, the manning of the hospital. So we're taking a holistic approach which prioritizes Alaska, and that is one of the chief's top concerns, priorities.
Well, thank you for that. And we have included in our Arctic Warrior Act provisions 2 authorizing provisions for troops stationed there in Alaska. One's for cold weather duty pay. The other one is a requirement that service members in Alaska be reimbursed for the cost of a flight home. And when you think about financial stressors, the things that just people cannot handle anymore, if they need to be reconnected with family and they can't afford the $2,000, $3,000 flight home, or they don't have the cold weather gear, or another issue that we hear is pay systems, that the service members are literally victims of outdated technology. They don't get paid on time. We've heard from some young servicemen that it's taken up to 7 months to get their paycheck situation squared out. I don't know how that works, but when you have that kind of financial stress on our service members, that's not right to them. So I'd like that again, as we're looking for considerations to be factored in as well. Mr. Chairman, thank you.
Senator Shaheen.
Thank you, Mr. Chairman, and thank you to each of you for your testimony today and your service to the country. Our office is still hearing, fortunately not as often, but still hearing from people who have been affected by anomalous health incidents. I don't know if this is for you, Dr. Martinez-Lopez, but can you speak to how the department's understanding of those incidents has evolved and to what extent you believe people who have been affected, both military members and their civilian family, are being treated now?
Overarching, ma'am, we need to take care of these people. They're sick. So when they come to our system, we have interagency agreement and we have processes to bring them. You help us out with that. We're going to take care of them. We're still doing research, trying to figure out the causality.
Right.
That's going to take time. But the overarching, like with anything, we need to take care of the people first. And then with the best science we have, develop the science as we learn more, close that gap, right? But it doesn't stop. So we're going to need the help from you to sustain that effort.
And what I have heard from people who have been affected is that they especially appreciate the care they're able to get at Walter Reed Medical Center. Can you tell me if Walter Reed is still open to those people who have been affected by AHIs, not just within the Department of Defense, but across the federal government?
Ma'am, we're very proud of that team, and I think the general can speak about that.
Yes, Walter Reed is continuing to care for AHI.
Thank you, and it will continue to do that.
And it will continue to do that. Yeah.
Thank you. So I maybe want to ask each of you this question. What percentage of your force are women? Admiral Gillingham?
I would have to get back to you, ma'am, but I believe it's approximately 30%.
General Miller?
Now, Air Force overall is 21%, and within the AFMS, it's 50%.
Thank you.
Ma'am, I'd have to get back with you the specific numbers.
Dr. Martinez-Lopez, across the entire military, can you tell me what it is?
I'm told 18%.
18%, and that number is going up, is that correct?
Yes, ma'am.
So that women make up a very important part of those who are serving on active duty. Perhaps this is for you, General Crosland, what contraceptives are currently available to service members?
All contraceptives are currently available to our active duty women. The Defense Health Agency's rolled out walk-in for contraception in all 133 of our clinics that offer that capability, to include some of the long-acting contraception, so they can walk in and be taken care of without a referral or an appointment.
And is that the case for people who are deployed overseas as well?
It is a case for the people who are deployed overseas when they have access to the capability within the theater. So if the clinic provides long-acting, then they're able to walk in and get long-acting.
And can you tell me what percentage of women are deployed in places where they can't get access to those contraceptives?
I do not have that number, or what locations do not have the capability to provide it.
Is that something that someone within the office is able to provide?
We'll take that for action.
Okay. We hear from women on a pretty regular basis who tell us that they are in places where they don't have access to contraceptives. Service members and their families are affected by eating disorders at elevated rates compared to their civilian counterparts. And the SERVE Act was passed in fiscal year 2022 in the NDAA, and it was designed to expand access to eating disorder treatments for service members and their families. Can you speak to the options that are now available as the result of the passage of that, and has it been fully implemented? I guess this is for you, Dr. Martinez-Lopez.
Ma'am, I don't know the answer to that one. I owe you a response.
Okay.
Anyone else knows? Okay.
Well, thank you. I think it would be, I would appreciate hearing that response, as I'm sure the full committee would, subcommittee would. And I think as part of that, it would be helpful to know if spouses and children of service members are provided the same level of care as active duty service members. Thank you. Thank you, Mr. Chairman.
I want to welcome the newest member to our subcommittee, Senator Murphy.
Thank you very much, Mr. Chairman. It is an honor to join this prestigious subcommittee, and grateful for the opportunity. Thank you all for being here today. I'm really grateful for the chairman, the ranking member's focus on the suicide epidemic and for all of the work that you've put into it. I wanted to talk to you, Rear Admiral, about a very specific case that I've become intimately and tragically familiar with, and that's the death of 7 sailors on the USS George Washington just last year. One of them was a Connecticut resident, seaman recruit Xavier Sander, took his own life with a service-issued firearm. And by now, you know that the conditions on this ship and the conditions for these sailors was, frankly, just unacceptable. This was obviously a ship that was going through a major refueling and complex overhaul. The conditions on board required a lot of these young men to be sleeping in their cars, to be making long trips home, to get away from the chaotic scene, and the access to mental health was just completely inadequate. Sailors who were seeking routine care on a ship that had significant conditions affecting mental health were facing waits of up to 2 months for care. Members of Seaman Recruit Sanders' division reported that they were often hesitant to seek mental health treatment through Navy channels because they were under the impression that it would affect their future career opportunities. Obviously, this is exceptional that we had so many individuals take their life in a short period of time, and I know that there is still a final investigation that is outstanding, but what can you tell me today about how we're changing conditions for our seamen who are living under these kind of conditions, and how we're making sure that they have access to mental health services?
Thank you, Senator Murphy. From the Secretary of Navy on down, we have taken this issue very seriously, as we have taken the general issue of mental health and suicide prevention seriously. I can tell you that our immediate response was to send a special psychiatric response team. That was to counsel those who were directly affected by these incidents, these tragic incidents. We've learned also that it's important not only to respond acutely, but to have a prolonged response. And so all of the members of the George Washington are enrolled in what's called Orion, which is a periodic check-in to assess how they're doing and ask if they need help. Historically, when we've done this on 5 previous occasions, we have about a 20% take rate, and we directly do a warm handoff for those individuals. But the larger issue, sir, is ensuring that we're creating a resilient force. GW certainly is an example of a challenging situation to be in a shipyard like that. But our sailors and Marines face challenging situations worldwide, and so developing force resilience is key. Toward that end, all of our recruits now go through warrior toughness training. They learn stress reduction techniques as well as meditation. These are reinforced through their training. In addition, for the GW and for the greater Navy, we have an expanded operational stress control program. This is a train-the-train model. In addition as well, our Office of Navy Culture and Force Resiliency just rolled out a mental health playbook, which provides tools for unit-level leaders and beyond, ways to prevent suicide, ways to recognize an individual in distress.
All right, thank you very much. I'll look forward to follow up with you on that. I just want to sneak in one more question, and that's to you, Mr. Assistant Secretary. We talked a lot about this independent review committee report. One of their urgent recommendations was to address Section 1057 of the 2011 NDAA, which prohibits the Secretary of Defense from collecting any information regarding firearm ownership by active duty members. Now, I think this was due to some concerns about overreach, but I don't think that the drafters of that language contemplated the fact that it is just good medical practice if someone is in crisis to inquire as to whether they have a firearm at home, whether that firearm is properly stored and locked. And so I'm not going to ask you for your view on the law. That's a question for us. But as a rule, is it good medical practice for there to be gag orders on physicians as to what questions they can ask their patients, what information they can try to solicit from their patients?
As a physician, you know, the relationship between my patient and I is kind of sacred. I mean, because we talk, and I expect him to be truthful to me so I can help him. So anything that interferes with that interferes with good medical care. So that my position is that. I mean, anything that interferes with a good open discussion between the patient and a physician or a provider, not necessarily a physician, is not good for either of the two parties. If I don't know, I cannot help you. And if you cannot tell me, even worse. So we need your help to facilitate that process.
Great. Thank you very much. Thank you, Mr. Chairman.
Senator Hoeven.
Thanks, Mr. Chairman. Appreciate it. Thanks to all of our witnesses for being here and for all you do to keep us safe and take care of our men and women in uniform. I want to ask primarily about, well, first, some mental health issues and making sure that those services are available to our members of the armed services. But first, I'm going to ask Lieutenant General Miller about the cancer study that's being done in regard to, actually, the chairman state the Malmstrom Air Force Base. There were a number of cancer cases there, and in response, the Air Force has initiated a study on it to determine cause and, of course, make sure that anyone that needs treatment is getting it. I did talk to General Boussier, met with General Boussier, the commander of Global Strike Command, to ask him about it. But my first question for you is, how do you determine that a case of cancer or a group of cases of cancer are attributable to any particular cause?
Thank you, Senator. And yes, there is an ongoing study now based on General Boussier's request, as he's been offered the initial assessment from our team at USAF-SAM, and he has elected to conduct a study that will be led by that team at USAF-SAM in cooperation with other important agencies, the VA, the cancer societies, and others. But what is going on right now is there's a 10-member team on the ground, just left F.E. Warren. We're at Malmstrom. They're headed to Minot to assess what each base is unique and different, what the situation is like in each area, how that study could best be done. Because to get to your question, it is a complicated question, especially when you're dealing with multiple different airmen, guardians, different career fields, different bases, different timeframes, and even different cancer types to determine what might be involved, what the incidence is, and then, if possible, what might be a causative reason that we would then take action on, since our priority is the safety and health of our airmen and guardians. So this is a process that will continue to play out over the next 12 to 14 months as we take this very seriously and try to get to the bottom of some of these concerns.
Do you have any sense of timeline at this point?
12 to 14 months is a reasonable estimate. Now, the study will play out in stages, and obviously, as they get information, if there's something actionable prior to that, that will happen. In the same regard, certain paths may result in more work being done that could extend this out, but the key is timeliness and trying to get this completed as quickly as possible to best take care of all that might be impacted, whether active, retired, all beneficiaries. And once again, partnering with others like the Veterans Administration, understanding all that potentially could be impacted.
Thank you. The True North, Task Force True North, is something I've worked on with the chairman of this committee and also with Air Force leadership, Secretary of Air Force and so forth. In the initiative, the True North initiative, is there a concerted effort to make sure that you're addressing mental health care adequately across the missile bases?
Yes, Senator. That's a great question. And True North is the initiative that the A1 community in the Air Force is rolling out with the focus on mental health in a mirror framework. SG has something called operational support teams that will be at Minot, that will be at every one of our 76 Air Force bases, knowing that our airmen and guardians, the two main reasons that they are often not deployable or have issues, it's mental health and it's musculoskeletal. So as a part of teams, 5-member teams that will be embedded in the med group, will go out to units for short periods of time, 8 to 9 weeks, develop trust, do prevention. Mental health will absolutely be a part of that effort.
And it's addressing family needs too, not just the service member, right?
And that's a great question because family is equally important. OST is based on the active duty members. For the Air Force, we've created something called Developmental Behavioral Family Readiness Centers. So there are 8 hubs presently throughout the United States that will address, we know that there's quite a few children that are impacted by mental health issues, that these teams go out to bases on a quarterly basis and then support virtually from afar so that a Wright-Patterson, for example, is a hub that could go out to a location like a Minot and provide that type of support. Those teams right now are focused on children, but could be expanded to include adult mental health providers that could take care of dependent family members that have mental health needs.
Well, with the indulgence of the chairman, one final question, and make it short, please. I am past my time, but both for Dr. Lester Martinez-Lopez and also for General Crosland, through TRICARE, are you providing enough mental health services and providers for our service members?
I'll defer to General Crosland.
So, sir, there's not enough in our country to meet the demand, to be honest with you.
I'm asking the question.
Yes, sir. So we're doing our best with the contract, and as some of our teammates have mentioned, taking a much more holistic approach, partnering with other teammates to help folks with their mental health, not just medical.
And it is a focus.
It is absolutely a focus.
Thank you. Again, thanks to all of you. Thank you, Mr. Chairman.
Just one quick follow-up on Senator Hovind's questions is for you, General Miller. What role is the Defense Health Agency playing in the assessment that's that the Air Force is doing under General Boussier?
There is a partnership there, and we're in open communication. So the Health Surveillance Division, part of the DHA, is absolutely involved. So it's important to us that this is in all the key organizations are playing a role, like as I mentioned, VA, American Cancer Society, and others, with an interest that once a study is completed, we may need to have some civilian organizations to be involved to be another set of eyes based upon the results that we receive.
Thank you. We appreciate all of you, your testimony, your opening statements. Thank you for being here today. This was a helpful conversation, covered a number of topics, but our oversight responsibilities will not stop here. Later this week, the subcommittee will receive your budget request and will conduct a thorough review. We ask that you provide responses in a timely manner and continue to keep us apprised of the Department's health policy decisions and implementations, similar to what I said earlier in this meeting. The Defense Committee will reconvene on Tuesday, March 28th at 10 a.m. for a hearing with the Department of Navy. We stand at recess.